final sort of debate, and maybe it's already been settled, I'm not sure. We thought we'd sort of probe the issue of the laparoscopic paradigm versus the endoscopic paradigm, and the turf issue, once again, of surgeon versus gastroenterologist. So to take the laparoscopic surgical approach, I asked Jeff Hazey to take that stand.
Thank you, David, and certainly thanks to SAGES to allow me to come and talk about this. If anybody is in the audience and they're expecting to see a steel cage match between Tony Clue and myself, go ahead and leave, because you're not going to get that from me. I think what we're seeing happen with notes is something that we've seen happen in the last 10 or 15 years in a couple of other specialties. We saw it happen with the marriage of interventional radiology and vascular surgery. We saw those two specialties come together, and now you see both interventional radiologists and vascular surgeons doing endovascular stenting and doing wonderful work. Same thing maybe with the cardiologists and the cardiothoracic surgeons, although cardiothoracic surgery teams haven't been as aggressive in adopting some of that new technology. But you see a marriage, and now the cath labs don't look like anything like they did a couple of years ago. You're seeing a marriage between an operating room and a less interventional suite. And I think that's what you're going to see with natural orifice surgery. And how can I make this go? There we go. I think I got it. This is my disclosure. So everybody knows this was a marriage. It started out as a marriage, and I think it's going to stay a marriage between the ASG and SAGES. When you're asked to give a talk like this, you don't want to come up here without any data. But where do you get this kind of data to make your argument? Should surgeons or gastroenterologists be performing notes procedures or something of the like? Somebody advance the slide for me. Yep, that's the one I'm used to. So what I want to do is actually get some data from meeting, course sponsorship, and attendance, and see if we can't make a point with this. So the first no-scar meeting, and I'm going to go actually very quickly through this to allow Tony an opportunity to speak. In July of 2006, there were approximately 150 attendees. This was by invitation only. So you had to have a gastroenterologist and a surgeon both attending. So you had a 50-50 split in the population. Actually went through the database here. The second no-scar meeting in Boston in July of 2007, there were 186 registered attendees that were physicians, 408 total registries. ASGE individual and team registration was 53, or only just over 25% of the people who registered for this meeting were ASGE members. SAGES members, though, logged in at just under 63%. Combined teams, just under 10%. We'll wait and see what happens at the third meeting in San Francisco in July of 2008. You're looking at courses. Who's doing the courses around the country? Certainly in North America, New York Presbyterian, Case Western Reserve, and Ohio State University, these are all surgical courses and sponsored by departments of surgery. Who's doing the research? No-scar, you need funded projects. We know that there have been 12, 9, and 14 funded projects, and there's another round of funding, I think, that they're due in the end of April. Took a little while to get this, but of the 12 funded projects initially, 7 PIs were surgeons and 5 were gastroenterologists. Of the second round of funding, there were 5 surgeons and 4 gastroenterologists. In the third round, 8 and 6. So in total, about 20 surgeons and 15 gastroenterologists as PIs were funded by no-scar. So you see a little bit of movement towards surgery. Citations, this is actually a recent Google search, appears to be the theme of the day. Just over 25,000 citations. But a good mix between presentations of both SAGES in 2007 and DDW in 2007. Now, who's done much of the animal work? Animal work to date, including appendectomy, ligation, cholecystectomy, splenectomy, etc., have been done by my colleague Tony Kalu, who's going to come up here and speak in just a moment. But Paul and Chris have all done excellent work historically. But who's doing the human work? Well, the first appendectomy, obviously, and tubal ligation were from India, and you just heard this speak. And some of the human procedures to date, as part of Dr. Melvin's talk, I used some of his data that he collected in looking at some of the procedures that were done on humans. The vast majority of the human work has actually been done by surgeons, and we're starting to see that both as published and unpublished data. We use diagnostic techniques at Ohio State, number of diagnostic techniques looking at contamination of the abdominal cavity, the trials in diagnosis, trocar placement, looking at the anterior abdominal wall, which we spoke of, and then our large trial to include at least 34 patients to put this head-to-head with laparoscopy and laparoscopic staging techniques. So as far as therapeutic techniques go, if you come away with one point, the therapeutic techniques are going to be done by surgeons. The diagnostic techniques, I think, have a wonderful opportunity to be done and performed and participated by gastroenterologists. One of the reasons that the surgeons have been very involved in the human studies and in therapeutic techniques is because many of these are hybrid procedures. Many of the procedures that you saw today necessitate some type of laparoscopic visualization or laparoscopic backup or some kind of a transabdominal port for retraction to allow you to perform the procedure. Transvaginal access is something that really isn't in the wheelhouse of a gastroenterologist, and similarly, single port laparoscopy, which may or may not be a bridge, is something that our GI colleagues are not very familiar with. This is our diagnostic study, and in the interest of time, I will skip right through that. And I want to thank you for allowing me to speak, and hopefully we'll entertain any questions.
Our last speaker, fittingly, deserves probably most of the credit for starting the whole notes movement. Dr. Kalu, as you know, was the first to report the notes technique. And Tony, what year was it at DDW, the poster? 2002? 2000.